All right, gang, I think we are gonna go ahead and get started. It's a few minutes after 6:30. We do have some more people who are registered to be coming in person. We did hear there was a car accident, so if hopefully maybe they'll trickle in, but I want to make the most of everyone's time, and of course, respect Dr. Rodriguez's time for coming tonight. So thank you all for being here. I have to say it's a small group, but I'm excited to have obviously some very familiar faces and a couple of, I think, newer ones as well. Is this your first time coming to the Breast Cancer Network? Okay, great. Well, we are really glad you're here. This is one of our monthly seminars, our learning series. And we also, for anyone who maybe isn't familiar, we have weekly restorative health classes, which means pretty much every day we have some sort of class going on here in this space. We have Zumba, Miriam, we have Tai Chi, Qigong, yoga, general exercise class. I know there's some others. We have a paint night that goes on here. We have regular support groups that meet. We have one both for kind of general support group, and then we have one specifically for those living with metastatic breast cancer. And we usually have a support gathering after this tonight. So Judy is normally the person who facilitates that. She couldn't be here tonight. So if anyone wants to stay, I will gladly stay, and we can share some time together and just kind of, see if anybody needs to talk through anything or wants more information or just whatever. We'll be there for each other. Okay. So even though Judy's not here, I will gladly facilitate a group tonight. I would like to thank Nancy and Karen, our wonderful volunteers who always handle the kitchen and bring us delicious food to eat, including homemade cupcakes. So thank you for that. That's the downside to Zoom, is that you don't get to dine with us. We also have we have some of our board members here tonight. We have Sharon and Sue. We actually have a brand new board member here tonight, Miss Rachel Wallmeyer. We are very honored to say is now on the board of directors for BCN. And normally we would have Debbie and Rob here. They were both unable to attend tonight. So I am going to try and remember a couple things coming up, because I don't have Debbie's very organized agenda that I always appreciate and rely on. So next coming up, we actually have, this is for Great Lakes Cancer Care. We're co-hosting an event with them, and it's actually going to be about pain management. So it's Get Moving to Manage Pain After Cancer Treatment. It's a free workshop, and it's going to be February 23rd. It's from 6 to 7:30, and it's going to be at the Tri-Main Center in Buffalo on Main Street. So if you go and RSVP, you can actually, if you want to do that tonight, there's a nice little QR code. Miranda is also newer to BCN, and she's been doing wonderful administrative work and social media work. And so if you don't already, maybe follow us on Instagram and Facebook. And she's helping create these fantastic flyers. So there's really easy ways to sign up, and all the details on getting to that particular event are there. A reminder that this night, this particular series is normally the second Tuesday of the month. However, for March, it will be the third Tuesday. It's actually going to be March 21st because it was like, we really wanted these speakers, and that was the only night they could do it. So next month, we're going to be hosting a holistic approach before, during, and after breast cancer treatment. And it's going to be with Dr. Leonard Kaplan, who is a DO, doctor of osteopathy. He's board certified in physician medicine and pain medicine, and along with Kim Howes, who's a naturopathic doctor. So she's board certified and licensed in naturopathic medicine. And so the topic is going to be learn how naturopathic medicine can be used to support breast cancer patients pre and post treatment to improve overall health. So I think this is going to be a really fantastic seminar. I know it's a different night, but hopefully you guys can fit that into your calendar. These are all on our website as well, and they'll be coming up on social media too. Our TLC codes, we are still handing those out within 6 months of diagnosis. So if you happen to know anyone who is more recently diagnosed, and they haven't, become familiar with BCN yet, or they could use some information, some resources, and some comfort, please do send them our way, because we have our TLC totes that we can offer to them, and it's a really nice thing to just kind of get started in this process. I think that's it. Talked about the health classes. I talked about the support groups, monthly education series. We also, that is technically those books over on that bookshelf there. That's a learning library. So you are welcome to borrow books from here and enjoy them. If you have something you want to pass on that seems relevant, you can always check with one of our volunteers and see if you have any books that you want to share. And then we also have a book club, which doesn't get a lot of love. So I wanted to bring that up, because I didn't even know until like a few months ago that we had a book club. So we do have a book club also on the website if you have any interest. And I'm going to stop there. And in case I actually didn't say it, my name is Amy Hartle. I'm on the board of directors. I'm an oncology massage therapist and lymphatic drainage therapist. And I'm also a breast cancer survivor. And we're just very glad to have you here tonight. So I'm going to introduce Dr. Luke Rodriguez. He is a breast oncology fellow at Roswell Park, and he's going to give us all the details on breast reconstruction, and I'm very excited about it. So thank you. Thank you.
All right, thank you guys for having me. Thank you for the introduction. So yeah, she mentioned I'm one of the breast oncology fellows. So this past 6 months, and that's 6 months to follow. I'll be in the oncology department, just kind of seeing different aspects of breast care, breast cancer treatments, and reconstruction and such. My past, I did 5 years of general surgery. In those 5 years, I was very exposed to a lot of breast cancer care, including reconstruction. And hence the reason why I want to talk a little bit about reconstruction to you guys. My focus actually long-term is to be able to incorporate this in my own practice and such. This is a table of contents. So I'm going to talk a little bit about basic anatomy, historical management, how things were first done, and then how we're treating things nowadays. Mastectomy types, and different types of mastectomies, and then get into the nitty-gritty of reconstruction with prosthetics, so tissue expanders and implants, and then analogous, in other words, kind of free flaps or flaps to help cover the area. So the objectives are as following: just kind of review past surgical management, changes of the changing aspects of surgical mastectomies, and discuss the different reconstruction options. I have no financial exposures. There you go. So general anatomy: the breast is attached to the chest wall. It consists mostly of fat and tissue, but the actual breast tissue itself, being the organ of the breast, consists of ducts that terminate at the nipple, and at the very beginning of these ducts are little lobules. This is what produces milk, and the milk goes through the ducts, and at the time of pregnancy, begin to get excrete milk for the infant. Typically, breast cancer itself arises the majority of the times within the ducts, and secondary to in the lobules, and then there's a very small percentage, about less than 3 or 4%, that can arise elsewhere in secondary breast tissue. The breast is over the chest wall. Right underneath it is the pectoralis major, which is the major muscle that most of the guys really want to show off when they go to the gym. And right underneath it, there's the second one, also called the pectoralis major. And it's just over the chest wall and the actual ribs itself. So looking at the general anatomy, the breast has a very robust blood supply. Typically, it comes from 2 major vessels. One's the internal mammary, which is right here, and the secondary is the lateral thoracic artery here, and it kind of circumferentially supplies blood to the breast itself. Now, when we talk about blood supply, we have to talk about blood going there. It has to leave. That's where we talk the venous supply. So it can come back to the actual internal mammary vein, go back up to the big vein, it goes back to our heart, or it can also go to the lateral thoracic vein, which goes to the axillary vein, which then drains back into our heart. The lymphatic system. So lymphatic is kind of what cleans the blood out, takes certain debris, and then has our body kind of recognizes any type of pathogen or anything going on. Those follow the same tracks of the lymphatics. The lymphatics travel along with the veins. In breast cancer, things we worry about whenever there's a cancer is it invading the lymphatics. And what we check mostly is in the axilla or the armpit area, where there's a large abundance of lymph nodes there that we can sample to see if breast cancer is left the breast and gone potentially elsewhere in the body, and this would be the first area. So for general statistics, as you get older, the likelihood of potentially presenting with a new form of breast cancer or breast cancer itself gets more prevalent, more common. Overall, from birth to death, it's about 1 in 8 women, so about 12%, 13%. But as you can see, 1 in 48 from birth to 50, about 50 to 59 gets 1 to 41, and this number becomes more and more closer to that of 1 of 8. So the older we get, the more likely it's potentially we're going to have a breast cancer develop. As far as overall statistics, breast cancer, as far as new cases diagnosed, is the most common in females, secondary to lung cancer. As far as estimated deaths, lung cancer is the most common, secondary to breast cancer. So over trends from 1970s to closer to the 2000s, you can see males compared to females, lung cancer is both present on both, but there's definitely a different change for males with prostates because women don't have any, but males don't have that much breast tissue, but females do. And the breast cancer itself, as far as diagnosis, is increasingly over the years and kind of maintained steady over the past couple of years. And this is secondary to imaging and surveillance and kind of overall public knowledge of we should get checked early and continue checking on a yearly basis. So historical management, way back when the first cases of breast cancer and kind of management was back noted in the Egyptian times of 3000 to 1500 BC, where they didn't really recommend much management for these cases. They just recommended just kind of cauterizing, taking hot irons and putting on top of the breast. It wasn't Hippocrates, which is kind of one of the godfathers of kind of beginning of medicine, actually advocated to not approach do much as far as surgical excision for breast cancer because the risk of bleeding and that actually being a curative intent was not well documented. This was also held true for multiple years, and this is pretty much what these two other pre-modern day mentalities were about treating breast cancer. Typically, if you're going to have it, you want to have it early so they can potentially treat it, even then the risk of recurrence, and in other words, this coming back or having secondary issues such as bleeding is very high. It wasn't until about the 2nd century AD where one of this would be kind of the first surgical oncologist where he advocated kind of doing a secondary incision or incision away from the actual tumor and potentially removing it that way. So you're not going in this very highly vascularized tumor and potentially lead to more bleeding. So he recommended doing an alternative incision. And he also advocated kind of taking a hot iron and putting over the breast to kind of help stop the bleeding. So very gruesome, if you can imagine how things were back in the day. It wasn't until the 1500s where there actually was more knowledge of how this may have spread and different means of removing the actual breast and also the underlying tissue, which was the pectoris major, that big muscle underneath. And this was one of the Spaniards, Michael Cervantes, in the 1500s, who advocated removing all the lymph nodes that were in the armpit and also removing the muscle itself. So it wasn't really till the 19th century where we began to have a little bit more advances in using more scientific based approaches as far as breast cancer. In the 19th century, had secondary advances with general anesthesia, where it wasn't so much kind of cold blood, pretty much. We're kind of at least giving more comfort to the patient. We had more aseptic techniques, so we understood kind of what should be clean and what shouldn't be clean, and when we should not be using dirty things on people. And there's also thing too is that with these different years, there's also different approaches in which people would treat breast cancer. It wasn't until William Halsted in the late 1800s developed the first technique that was published multiple times and had reproducible data. And what he advocated was similar to what the Spaniard and then 1500s, which was removing the actual muscle, removing all the lymph nodes, and then closing the incision if possible with skin, if not from the second area of our body, skin over that muscle, over what was left behind. In his approach, the recurrence rate, in other words, the cancer coming back, was only that of 7%, which is much more acceptable than how it was previously before. This is a result of what he described. So removing the breast tissue, removing all the muscle that's underneath it, all the lymph nodes, and you're left with this result. 7% sounded great. Reality, you're left with this. So you can only imagine how this was disfiguring for the person having, and also had secondary issues, or not issues, but debilitating, because you're removing a large amount of muscles and nerves that make your arm less likely to be able to be used as it was before. So in the 20th century, we developed the use of x-rays and realizing we could use x-rays and implement for cancer treatment. This was Gregory Keenes in the 1900s who began to introduce radiation therapy to the breast. And it did not gain popular at the time. It's still radical mastectomy was considered standard of care, but it wasn't until the late 1900s, almost the 1950s, where Pate, Bison, and McFarlane began to do what they call a pectoral sparing. In other words, leaving the muscle behind and just taking the breast tissue itself with the lymph nodes, and then also introduce radiation into the field. And this is where kind of the beginning of radiation therapy and removing and preserving some of the chest behind, where kind of breast conservation therapy kind of began to develop. So mastectomy types, there's different varieties, and we just showed a very kind of gruesome, if you want to put it that way, approach, which was removing everything. So since this was the standard of care until the 1970s, we had to have data showing that we didn't have to do as much of a resection. And this is one of the big landmark studies, which was called NSABP4. And what it did, it compared the radical mastectomy, which was removing all those muscles, all those lymph nodes, all those nerves, compared to if we left all those muscles behind, took just the breast tissue behind, took the breast tissue and the lymph nodes. How did that change in survivability and include radiation into the factor two? And what we saw was that the 10-year follow-up of these patients, there was no difference if their node, the lymph nodes were positive or the lymph nodes were negative. There was no difference in survivability and outcomes of these patients. And in the 25-year mark, it also demonstrated the same thing. So what this allowed us to implement less extensive surgery, less defigurative surgery, and leaving the pectoralis major behind or the pectoralis muscle behind, and allowing still people to have more function with the arm itself. So this being the basis of how we began to approach things, we began to ask the question, what else can we do? So this is what a simple mastectomy would be. So when we're talking about just removing the breast tissue and closing everything, oops, go back then, I'm sorry. It's considered a simple mastectomy. If we're removing all the lymph nodes, is what you might hear out there called modified radical mastectomy. That means removing all the lymph nodes and all the breast tissue with no plans for reconstruction, essentially. So the goal is to do an elliptical incision, kind of like an eye, if you want to put it that way, over the nipple, remove the breast tissue, but leave skin behind and leave the muscle behind, and then eventually just close it. And this is an example of such, removing the breast tissue, leaving a skin paddle here and around everything, and then putting a drain in place to remove any fluid that would build up so things can begin to scar down. As you can see, there's not a lot of laxity here to kind of even consider reconstruction. It wasn't until about the 1990s and such that we began to implement different aspects of mastectomies. And this is where the skin sparing mastectomy came into play. From an oncology standpoint, the concern was if you're leaving excess tissue that might contain breast, would this change outcome as far as recurrence? In reality, there was actually no changes in outcome. So this is where skin sparing mastectomy became a viable option for patients who were seeking reconstruction. And this consists of similar, but the markings are a little bit more smaller, if you want to put it that way. And we're typically removing the nipple at this time, but removing all the breast tissue, as you can see here. And you have this very large amount of skin left behind, and when you close, you can see there's very redundant skin. And this skin, what it offers is a possibility to put an implant in or an expander and fill that space so that we can keep a normal contour of the breast and begin to do reconstruction, compared to a flat closure where things are kind of might be under a lot of tension, and putting something else underneath that space might increase the risk that there's complications with the skin itself and lead to an infection or just a wound breakdown. So it wasn't until, again, late in the 1990s, close to the 2000s, where we began to push it even further. And what this one was the nipple sparing mastectomy. So this was, again, from an oncologic standpoint, we're leaving things behind, but how much can we leave behind and be safe? So research has shown us that the outcome is as long as you remove sufficient breast tissue, and there's certain criteria which we'll touch shortly, Patients can actually preserve even the nipple itself. And from a cosmetic standpoint, this is kind of the closure. You have an incision underneath, you leave the nipple, but remove the tissue under the skin, which is this is the skin here, and that's on top of the chest itself. And you're left with this empty space here. And then the closure itself would look something like this. This is called the nipple sparing mastectomy. There's different means of approaching it. You can do an incision around the nipple, an incision underneath the nipple, and a little vertical like this, or one that goes either towards the middle of the chest, or an inframammary incision, which is what this patient has here, or what they call an omega, because it looks like an omega. It encompasses around the nipple, but leaves the nipple behind. And this space here is what serves to be able to put in a tissue expander on the implant. So nipple sparing mastectomy, there are certain criteria. These are kind of standard criterias. It is subject to change. There has been a lot of research moving forward for patients interested in such. I can't speak specifically for Roswell because it is provider dependent. But typically things we look at is how far is your cancer away from your nipple itself. If we're talking about leaving things behind, we want to make sure they're not involved with the cancer. So typically greater than 2 centimeters from the nipple to the cancer is one criteria. And also can be used for patients that have prophylactic or prophylaxis, such as people who have BRCA mutations and such, that there is no cancer there, but there is an increased risk in the future. As such, they want to get things dealt with before it becomes the cancer itself. So this is a patient, this is one of the good patients to be able to receive a nipple sparing mastectomy. Contraindications for such are people who have the cancer either abutting or involving the nipple itself. Again, it makes sense. You don't want to leave the cancer behind, go through this whole process and have this come back. Patients that have a certain type of breast cancer called inflammatory breast cancer, those are patients that unfortunately aren't candidates for this type of mastectomy. Or patients that have cancer discharge. In other words, the cancer is into the ducts and it's expressing through the nipple itself. Those are patients, unfortunately, aren't really candidates for this because the concerns are leaving these cancer cells behind. Other consideration is patients that have very large breasts. Reason being is the skin that's left behind is a little bit compromised. And the larger amount of skin you have, because you have large breasts, the higher likelihood you're going to have skin issues from the reconstructive standpoint, or the nipple itself might become devascularized or just lose the blood flow and die off. And obesity, just because they're the same concept, there's a lot of tissue there, and the more tissue you remove, the higher risk there's potential for the nipple dying off or the skin itself dying off. For breast reconstruction, so kind of jumping into, why do people choose breast reconstruction? Why did they decline reconstruction? So overall, breast reconstruction kind of helps regain the feeling of femininity and wholesome, and improves their self-image. It prevents clothing limitations also, and also prevent an external breast prosthesis. But why do people decline it? Some people fear of complications. It does require more surgery, and there's something in you that's foreign, so there's a potential for a potential complication. Belief that they are too old. In theory, no one's too old for reconstruction. Reconstruction is always a potential option. Or fear it might interfere with cancer surveillance and treatments. There is some sort of truth to this, but we'll touch base shortly on that. But for surveillance, once we're done with kind of the reconstructive standpoint, you still follow with your surgical oncologist or your oncologist, and they do routine screening, and they screen you as they should, depending on what you had done. So the surveillance itself is still there. And of course, this assumption is you still do follow-ups with your providers as such, and do the recommendations for the surveillance. So benefits from reconstruction. Well, it restores psychological well-being. It's not considered a cosmetic procedure and this is from the 1990 Women's Health Cancer Rights Act, where this allowed coverage for reconstruction for all patients who had breast cancer by all insurers. There was no specific time frame as far as limitations, and the matching procedure to be covered for the contralateral breast. So if I had a breast cancer on this side, I had reconstruction, and I want things to match, in theory, it should be covered under this act. It also treated any surgical complications of all stages, and it eliminated the need for a breast prosthetic. So when you see your plastic surgeon, when you see whoever you talk about for reconstruction, there are some relative contraindications. They're not absolutes, but there are relative contraindications. If you have a very large cancer, it involves multiple parts of the breast itself. That might be a contraindication potentially for getting reconstruction. Smoking status increases secondary things such as blood vessels, clotting off. Also, the skin flap itself that we leave behind is slightly compromised, and smoking actually increases the risk of their secondary complications as infection. Obesity is the issue with that is there's so much tissue removed that a lot of the blood supply is also partially compromised. So these are considered some relative contraindications. If you've had previous breast conservation therapy, has radiation to the actual breast itself. The radiation has secondary effects where the little blood vessels also are questionable. So receiving this reconstruction can be a bit difficult. Previous surgeries to donors area. So there's when we talk about flaps and free flaps and such, there's certain things that might be contraindicated if you're looking for instance, like a deep flap or something of that sort. We'll touch base a little bit of that. And medical comorbidities, such as uncontrolled diabetes, increases your risk for infection, also increases the risk of having small vessels being compromised and leading to infection, and heart disease. So when we talk about reconstruction, there's kind of three options. There's what we call immediate reconstruction. What this means that literally one time you get your breast cancer surgery done, and at that same time they put the implant in, not an expander, just direct to implant. The advantages for this is immediate return of kind of body image, potentially a single stage, so just one surgery, you get everything done and that's it. It's better skin viability, better skin variability. And it's best for stage cancers that are relatively low, such as stage 1 or stage 2. And they are not expected to undergo radiation therapy. Disadvantages of this is that it's difficult to assess the mastectomy flap. If there's any concern that your skin paddle, your skin flap itself is slightly devascularized and you do this implant that's putting more tension on that skin flap, there might be a secondary risk of the skin flap dying off. So it's a bit difficult to assess the skin flap at the time of surgery. There are slight increased risks of post-operative complications, and these complications may also include delay of cancer treatments. Since let's say someone goes in, you get a reconstruction, they put an implant in, you have complications, it might delay your chemotherapy, it might delay your radiation therapy. So these are some of the disadvantages of considering going direct to implant, is what people call it. Delayed reconstruction. So this means that at the time of surgery, they don't do anything. They just kind of close you. And then later down the road, once you're kind of done with your treatments, then we talk about reconstruction, what options are available. The advantages is it doesn't affect your post-operative treatments, such as chemotherapy or radiation. It can be closely monitored. It also allows us to closely monitor if there's any concern that this might recur on patients who are high risk or have high cancer stages. If there's any skin or tissue that's damaged by radiation, it can be replaced at the time of delayed reconstruction. The disadvantages is you do lose that inframammary fold, so the lower aspect, you do lose a little bit of that fold. The vessels that they use for reconstruction also might be tedious. In other words, it might be slightly scarred down depending on what procedure you had done. We'll talk a little bit about that. The flap size requires required is usually greater. So when we delay reconstruction, things scar down. So sometimes when things scar down, we have less tissue to work with. So it might require a little bit more tissue from elsewhere in your body to kind of get the coverage you need. And it's like psychological impacts of timing of mastectomy defects. And then we have kind of like the in-between, the delayed immediate reconstruction. What this means is that we do a reconstruction, but it's not the full-blown reconstruction. We put, for instance, a tissue expander in. And this allows us to kind of keep that capsule, keep that area open. And then over time, depending on how your treatments are and what treatments are needed, we can either fill those expanders up and then switch it out for an implant. And this is pretty much what I was kind of implying. So skin sparing, because we leave the skin behind, put a tissue expander, and then it allows us to wait for the permanent pathology. Sometimes after surgery, there's things we don't expect. We go in, we do the surgery, we remove the cancer, we check the lymph nodes, and there's things that are questionable at the time of surgery. We don't know 100%, for instance, if you might need radiation, or we don't really 100% know that the pathology actually came back with a different type of cancer, that you might need radiation or you might need chemotherapy, for instance. when those situations happen, we don't want to subject you to a reconstruction that's immediate and then realize you need these treatments and have secondary complications that might delay those treatments. So for instance, if we're waiting for that final pathology, if they're negative, we can then proceed with the reconstruction as planned. But if they're positive, we might need to de-inflate, in other words, remove any air or any saline that's in that tissue expander, or remove the tissue expander and wait until after all your treatments are done to talk about reconstruction. So preoperative evaluation. So when we see you in the office, we always want to know, what cancer you have, what abnormal mammograms you have, previous breast surgeries, because that may play into how we're going to potentially do reconstruction, pregnancies, if you're planning on being pregnant, breastfeeding, future child plans, smoking history, comorbidities such as heart disease, diabetes, and also family support. And this is, of course, a process people go through, and having the additional support you need to kind of get you through those days that things aren't going as planned, or things are just not even expecting to be as difficult as they may be, just to be that additional support. Those are things that we consider when we talk about reconstruction. As far as physical exam, of course, we want to examine the breast itself. How big is the breast? Is it small? Is it large? Are things not exactly where they should be? Are the nipples sagging? Are they high? Are they this way or this or that way? Because that allows us to figure out what we need to do at the time of reconstruction to kind of get you proportionate and such, if we're doing one side versus the other. We also want to check the skin's quality, also the masses, where the mass is at. And also if you look at your abdomen and chest for any scarring, for instance, previous surgeries can also have effect as far as what type of reconstruction, if we're going to talk about a skin flap, what type of skin flap we might need to reconstruct the breast. If you had a previous C-section, we worry, for instance, when we talk about a deep flap or something of that sort, that the blood vessels we use to harvest might have been damaged during the C-section. If you've had, for instance, God forbid, you've had a bad trauma, you had to go to the emergently to the trauma bay and have what we call posterior lateral thoracotomy, where we go through the actual muscle in the back to kind of open the chest. That actually might take one of the reconstruction options off the table because of the damaged muscle and such. Also, as kind of we've talked a little about patient support, but patient support, recovery time, comorbidities, patient preference as far as the final reconstruction and the size and shape of the contralateral breast, and the need for any radiation chemotherapy. So typically when we talk about reconstruction, it's not 100% going to be exactly the same. There's going to be a slight variation, and it might be smaller than the normal breast that you have. So it's something we need to talk about. And when we talk about that, we can do the reconstruction and then talk, when we're done with this, the final product of then reducing at the same time the contralateral breast, so they look symmetrical. Patient education. So the goal is to achieve the most symmetric as possible. Obesity makes implant-based reconstruction difficult. And prosthetic breast reconstruction does not hinder detection of local or regional recurrence of cancer, for any would recur by any means. So prosthetic techniques. So it was in the 1960s where silicone implants really began to take a hold of the United States and became used for reconstruction. Popularity at that time was a one-stage reconstruction approach. So in other words, just going in and just putting the implant in at the time of surgery and calling it a day. The early tissue expanders, if they did use tissue expanders, were smooth. They had a remote filling ports. There was many problems with these implants, tissue expanders at the time. They could cause capsule retracture, which I'll show you a photo of what that means. Pretty much the capsule around the implant kind of calcifies because of potential bacteria exposure, and then causes kind of what looks like a very contracted breast and not so much natural falling breast. There was a poor, these tissue expanders also had a poor expansion of the pocket, and there was also problems as far as filling the actual tissue expander at the time because it was still new. The current tissue expander is a little bit better. They're a little bit textured in the back, which allows, and they're anatomically shaped, and they have filling valves that we can easily identify and fill. With a semi-rigid back, it also allows it to expand the anterior and lower poles of the breast, and the textured surface of these tissue expanders reduce the incidence of these contractures, kind of this calcium deposits around the actual implant or the tissue expander, hindering the way it should naturally look. Tissue expanders come in different heights, weights, and degrees of projection. So depending on how your breasts are, we can cater to which tissue expander you would need so that we can have the most symmetry from the contralateral breast, or just how it normally was before any surgery was performed. If you're doing a bilateral, for instance, both breasts are being taken off. So tissue expanders, this is the most common form of reconstruction in the United States. You must have healthy mastectomy flaps. So this is probably one of the most important things for reconstruction, especially if you're talking like combined case where you have a breast oncologist or a surgical oncologist doing the mastectomy and a plastic surgeon coming in to do the tissue expander, for instance. If the skin flap is concerned, if there's any concern, or if it's very dusky and worry that it might have little areas that are compromised, putting additional thing underneath it that causes tension will increase the risk of that skin flap potentially dying off and having secondary problems. So the best things to do in those cases are just to close and just see how things evolve, and then tack it down at a later date. The ideal candidate is typically someone who's thin, because the blood supply that we remove from the mastectomy is not all involved, because there's not a large skin paddle waiting for peripheral or outside blood supply to reach that area to allow for healing. And for the patients with normal appearing unilateral reconstruction. So the advantages of tissue expanders is lower initial cost. It's technically easy. There is no additional scarring, and it's a shorter operative time. The disadvantage when we talk about reconstruction with tissue expanders and implants is this capsular contraction. So if you look at this here, this is an example of such. This is the implant. This is what it should look like, and this is what a contracture is. So the capsule your body normally forms around the implant gets calcified, and it begins to kind of constrict the actual implant and changes the form. And this doesn't look as natural as it should, and this would potentially require a re-excision or removing of the capsule and removal of the implant, potentially putting a different one in at the same time or at a different time. There's also the possibility of an implant rupturing, possibility of infection requiring removal, and the likelihood that there's a high likelihood you need additional revision or future surgery too. So tissue expanders and implants. So there's a one-stage approach, which is what we kind of touched based on, where mastectomy is performed, and at the same exact time, implant, not a tissue expander, but an implant is placed in. The advantage is it's a true immediate reconstruction and it only requires one surgery. Disadvantages is it limits the size of reconstruction. If, for instance, you would want to go very large compared to how you were before, we're kind of limited as far as how much tension we can put on the incision itself and the skin flaps. Insurance companies are actually less likely to pay for any further revisions if you get the reconstruction RLA. And there's high rates of the skin flap or the mastectomy flap necrosing. Necrosing means that the blood supply is compromised and those little areas die off. Because again, we don't really 100%. We're putting a lot of tension under this skin flap and hoping for the best. And there's a high incidence of shape and volume asymmetry. Just because we put it in, things scar over time and move over time. So there might be asymmetry from both sides or from one side compared to the other. The two-stage approach, which I'd say is probably the most common approach we do, is kind of that delayed and immediate, as we mentioned before. So a mastectomy is performed and a tissue expander is placed. The reason why tissue expanders are in place is for a few reasons. One of them is it allows us to wait for the final pathology if we have any concern that there might be a change in what we expected from what ends up being resulting to be from your mastectomy from the cancer itself. And what the tissue expander allows us to do, which we'll touch base shortly, is that we preserve that pocket. We wait for your body to normally form a capsule around it that's normal, and then over time expand it. Implant is placed at a secondary surgery. So once we're done with the tissue expander, which we'll touch base on when we potentially remove it, we will then put an implant in its place. Advantages, it minimizes tension and stress to that skin flap at the time of mastectomy. So if there's any concern or if there's any little area that maybe wasn't thought of to be concerned, it allows it to revascularize if necessary. It also increases flexibility of choosing a final breast volume and shape. It offers a second surgery, which is covered usually through insurance for revisions if they're made. The disadvantage, it requires 2 or more surgical procedures to kind of get everything done. So it might take a while for you to kind of get the final aspect. It might take months, depending on how your treatments are and such. So there's two main approaches as far as tissue expanders or just implants in general. There's the subpectoral. So this is the pectoral muscle we mentioned before. They make an incision underneath it and make a space that the implant is actually underneath the muscle, and then take a piece of supporting tissue and then suture it to the muscle and around the implant and around the chest wall here, that over time your body forms a little protective area around this. And this is the tissue expander. And then at the very end, they make an incision, usually around here, remove the tissue expander and then put that implant in. It's underneath the muscle. This one's over the muscle. This is what we call a prepectoral breast reconstruction. So this is the tissue expander, or the implant is covered in this same protective matrix or this additional tissue material that we actually suture to the actual muscle in the chest wall underneath here, and then fill it over time, and then make an incision underneath or through it, remove it, and place the final implant. This is kind of surgical preference. The trends way back when, where this was done initially, back when we were started first doing reconstruction, then there was a large trend to move to this approach, and then things are slowly coming back to this approach. Now, this is surgeon preference. You can request it as needed, but it kind of ends up being if the surgeon feels comfortable doing which way they feel comfortable doing. As far as things with the subpectoral approach, is this can lead to what's called animation. So as we mentioned, this is a muscle. What happens with muscles? They flex. So if you would do any type of flexion with the muscles of your chest, it can cause increased tension underneath the implant, which can protrude it to go down or up. And that's what we'll call an animation to form, because it gets animated when you constrict the muscle. So that's one thing that's very well noted, or is a high potential being very noticeable, having this type of approach compared to this type of approach. This one does offer a little bit more of a natural look, just because it's using the natural curvature of the muscle itself to the lower aspect of where the breast tissue would be, where this one might be a little bit more noticeable, but there are different implants that can help with this. For expansion, so this is with the tissue expander, we typically expand, we put volume, in other words, it would be saline or air into that tissue expander to eliminate dead space. Your body doesn't like dead space. It fills up with fluid, and that dead space constricts or contracts over time. So as we begin to fill the expander, it takes up that dead space and allows it to be used for a pocket so we can put an implant in. It's not too extensive and not undue pressure to the it doesn't it's not too extensive and it doesn't cause that pressure to the mastectomy site. For post-operative care, typically about 2 weeks after surgery, we have a little magnetic device, because there's a little port that we can find with the magnet, and it tells us where we have to fill the air or saline, whichever your surgeon chooses. And then we fill about 30 to 120 cc's, depending on how large your breasts are planning to be. And this can be done periodically, at least once a week, till we get to the volume that we need. The goal is about 25 to 30% greater than the expansion volume, and it allows for the extra skin to be available at the time of the exchange, and it allows for excision of the previous mastectomy scar too. So it kind of just redoes everything, keeps that pocket. So this is what a tissue expander typically looks like. It kind of looks like an implant, but you have to notice this part here. This is what people use a magnet to help identify, because this needle, which is connected to a syringe, is what we introduced to here. It's a little rubber port that allows us to introduce saline, that allows us to introduce air. There's two types of way you can fill the actual expander itself. And then we have these little tabs here on the side, which are sutured to the muscle to kind of hold it in place. And here's a representation of exactly that. This is a subpectoral approach, but you see the implants underneath the muscle. It has this little area here that can be a bit difficult to feel, depending if it's over or under the muscle, because the muscle being on top of it. So using that magnet helps us identify it. We introduce that needle. We fill this expander to the size of this compared to this. This is much more expanded compared to this. Then at the time, once it's fully expanded, remove it for an actual implant. As far as exchange, this can occur at any time after expansion is complete. Typically, we wait about a month for the last expansion for the capsule around it to mature. So we have that pocket ready to go. If chemotherapy is given and you're expanded and you're waiting for the reconstruction, for the exchange for the implant, some people might wait up to a month just to allow for those any chemotherapy effects to kind of leave your body and metabolize, to avoid the risk of having secondary complications. Now you've been through this process for such a long time. As far as pre-op, we talk about which type of implant might be the best for you, silicone or saline. There's different changes now with silicone. There's one, it's called a gummy bear. That if the old saline implants, if I would make an incision on them, they would just kind of leak out a little bit and be very sticky. These new gummy implants, if you cut them and you expand them and try to release them, they just come right back. It's like a little gummy bear. If you cut like a gummy bear. Smooth versus textured implants. Smooth or mobile in the pocket, textured adhere a little bit more to the wall. The shape of the implant, round versus anatomic, and I have a slide showing exactly what that means. The anatomic maintains the dimension and form and any position, where the round is can vary as far as projection. It could be a high projection, low projection, intermediate or moderate projection. And intraoperatively, typically when we size you, we do have you you're of course asleep for this, but we do flex the bed, we do kind of sit you up a little bit to see how things look, what's the most anatomical. Sometimes though the space may be the same, one size implant might be a little better fitted than the other side, so we want to match them as best as possible, or give you a higher volume on this side if necessary, because this one didn't require as much volume. So as far as shapes of implants, there's the round and the anatomical. So the round, as you can tell, it just kind of looks like half a circle, where this looks like a teardrop. So what does this change? So it kind of ends up being the projection. If you have a round implant, you can see the superior aspect or the upper aspect of the breast is a lot more projected out, where a teardrop is a little bit more anatomical, kind of the way the breast would naturally normally sit. The thing that might change as far as what might be the best option is the nipple in regards, assuming there's still a nipple there, the nipple in regards to the implant. Usually for a teardrop, the nipple may rest a little lower, so a teardrop might project the nipple out naturally, where if I would use a round implant, the nipple might be projecting downwards. So it's something to consider as far as when we talk about implants of which might be the best for the patient. This is an example of someone who had a tissue expander, ended up getting an implant, or tissue was expanded and then ended up getting an implant. As you can see, the size different from one breast to another. So she ended up getting also a reduction on the opposite side to match one side with the other. And this in theory is covered by the Act of the 1998 Health Women's and Cancer Act. Here's an example of someone who went under a nipple sparing mastectomy. As you can tell, this is the patient's very slim, smaller breasts, and these are the typical candidates we look for people who are nipple sparing candidates. She had an inframammary incision, so an incision underneath where the skin fold is here. Had this area of the breast removed and had an implant placed. This is a patient, she's a different patient. She had an incision underneath, same approach. She has expanders in at this time. And at the time of exchange, she had an exchange for saline implants. And you can tell just at the natural curve, the natural lie of the breast, you can really see those incisions. As far as radiation and the prosthetic reconstruction, radiation is one thing we always worry about because of increased risk of complications with the reconstruction. Patients that have had prior reconstruction or may get post-op radiation have increased risk of complications. Prosthetic reconstruction has a higher rate of failure because of the radiation changes. That's the reason if you have a tissue implant in place, you need radiation, they remove everything from air, saline, whatever's in that tissue expander to avoid the risk of these complications. In the last decade, patients are getting more radiated than having been previously. And if a tissue-based or a tissue expander-based reconstruction is done, the skin should show no evidence of possible previous radiation. The pec muscle itself should not show fibrosis or scarring down. And there should be a slow and careful expansion of that tissue expander over time. And the reality is you always got to keep a backup plan in case things don't go out. So you always got to think of potentially an autologous flap or a flap or another means of reconstruction, which is what we're going to slowly touch base on. We kind of touched base a little bit. This is the lady in the reconstruction. There's kind of three options. Either as I mentioned, deflate and begin therapy if necessary, and then we expand after radiation. Rapidly expand and exchange implant before radiation. This is typically not done, and this one has a higher risk of complications such as capsular retraction. Or C, perform an analogous reconstruction 6 weeks after radiation therapy. So in other words, like a flap, and we're going to touch base on that. So analogous reconstruction is pretty much using your own tissue to help cover tissue or bring tissue to a different area. The advantages is it's like with like, it's your own body with its own body. There's no reaction in theory of rejection as potentially an implant or tissue expander may have, because it's a foreign object. So it's borrowing excess parts of excess tissue from other parts of your body and bringing it up to kind of fill the breast itself. It has an improved long-term outcome. The disadvantages can be very long with surgeries. I've been in surgeries where it's been 13 hours under anesthesia and such. There's potentially it's more complicated, so you need a very specific team, and people who have a lot of experience in doing these. There's a lot of donor site morbidity. So in other words, I remove it from my belly and bring it up to my breast. My donor site, which was my belly, has a risk of having secondary issues too. And there's always a potential that the flap that we use or the area that we use when we brought it up, some of it might be compromised and be lost partially or completely. So when we talk about reconstruction, I always go back to the basis of plastic surgery. In plastic surgery, there's a kind of a stepping ladder, which is when there's a wound, how do we reconstruct it? How do we close it? The very last one on this initial concept of plastic surgery was free tissue transfer. So talking about taking part of your body, taking it from the blood vessels there and bringing it elsewhere, connecting to the blood vessels in your body and bringing it to cover the area. Nowadays, this is actually accelerated. This has actually had better outcomes, and it can be treated, it can be done quicker, and it's no longer a last resort. So when we talk about flaps, I know I said flaps a couple of times. General principles when we talk about flaps is a flap is a part of your body that has its own blood supply. Tissue transfer maintains its own circulation. So in other words, there's the blood vessel that's supplying this area. We're removing the blood vessel if necessary, but making sure that blood vessel still works to supply the area. When we talk about a skin flap, for instance, for the mastectomy site, we're compromising the blood supply that would naturally go there because we're removing all this tissue underneath it. It's still viable because there's a lot more blood vessels around the area, but when there's a lot of tissue that we have to remove, you can see how this area where this other blood supply is might be a little bit not deliver as much blood to that area. That's the reason why these complications occur. So angiosome. So this is a concept from the 1980s where there's about 40 in our body, and these are dominant areas with typically certain blood or a named vessel going to this area. And knowing this concept, we can identify areas where we can potentially remove excess tissue with that known blood, the known artery, and dissect things around there, and then remove it and use that for reconstruction. Perforasomes. This is what we call perforators. Kind of going back a little bit. Perforator is not the main vessel, but a little branch here that's supplying this area. If it's a large enough vessel, we can use that to reconstruct and keep the major vessel behind, but remove the tissue and around that perforator to use for reconstruction. So how do we choose? So body types. Thin patients may not have enough tissue for these specific flaps. If you have no fat, for instance, to move around, it's very hard to do a flap in your case because there's not enough tissue you can use to reconstruct things. However, you can also use potentially multiple flaps if necessary, kind of stacked on top of themselves to give that volume if necessary. The breast size, typically if your breasts are large, you have to use a donor site that is the most available area of extra tissue. You can use a stacked approach or hybrid approach, which will touch base kind of like a flap on a flap to kind of give that volume. Things to consider as far as the abdominal based approach, which is very common, one of the most common approaches. We'll talk about what a tram flap is, but a tram flap might be a contraindication if you plan on getting pregnant in the future, because we have to remove part of the abdominal muscle, and if you're pregnant, it's going to cause stretching and secondary morbidity from that donor site. Where a deep flap or SIE flap is more favorable because we don't have to get involved in that muscle. And this could use tissue from other donor sites, such as the buttocks or the thighs, depending on your surgical history. As I mentioned, if you had a C-section, there's 2 blood vessels here that supply this area. So going through those vessels for a C-section might increase, might actually not make you candidate to get, for instance, a V flap, depending on how they enter the abdomen, for instance. Versus if I mentioned, if you had a trauma patient, you had to go into your chest and go through the muscle in your back, that might decrease that's going to eliminate probably your possibility of getting a flap from that muscle in the back. And also, this is very dependent on your hospitals and your plastic surgeon, what they feel comfortable doing and what their training has allowed them to be able to do for reconstruction. So now we're going to talk about the different flap types. So we're going to start with one of the very traditional ones, which is the LD or latissimus dorsi muscle flap. So this is the, so this is the area. Sorry, all right, this is the area of the back of our body. Right here, there's a large muscle, which I'll show you a photo. And what we end up doing is using a skin paddle here over the muscle and taking part of the muscle and the blood supply going to that area and bring it over and swing it to the breast to reconstruct and give that howling. So this was one of the very historic flaps used back in the 1900s, just for general reconstruction, not so much breast, but just kind of different parts of our body. The things we have to worry about when we try to consider this as being an option is, are you a patient that needs to get what we call an axillary node dissection, removing all those lymph nodes? The blood supply to this muscle is actually in that area. So if you've had a history of that, or you were planning on getting an axillary node dissection, it might impede the possibility of using this as a skin flap. Your previous surgical history, for instance, as I mentioned before, if you had an incision through this muscle, that's going to decrease that's going to eliminate your possibility of using this as a skin flap. You have to also assess the function of the muscle itself, and also a pinch test. This is a pinch test. This is pretty much taking the body and seeing how much of it can I take without causing a lot of tension. And you can see here, the thumb is here, the index finger is here. This area should, in theory, be enough that these two can potentially close without causing too much tension on the incision and having secondary problems of that wound not healing appropriately. So when to use it? Typically when patients have a poorly vascularized or irradiated area. So in other words, their blood supply to that area might be compromised, the bed might be compromised. We can use the muscle, which will have its own blood supply here, to then be brought over to the breast itself and reconstruct it and give its own blood supply that's not affected by the previous radiation we've had there. And it can also, help to use cover implants if you have an implant. Typically, risk factors include for patients that are diabetic, have excess weight, or tobacco use. So for this dorsi flap contraindications, this is the big incision through the back. As I mentioned, axillary node dissection. Advantages: it's a very reliable skin flap. It's easy. It's very easy to dissect. It's very versatile, and there's minimal donor site morbidity compared to other areas of the body. So this is the muscle itself. There's a very large muscle. There's one big predominant blood vessel that goes right to it, and that's what we have to harvest and keep intact so we can use that to cover the area, so this doesn't die off. There's small little vessels that also supply it, but this is the major one itself. So this is kind of how you would potentially be positioned, kind of with your arm up. We would mark you out, remove part of the muscle and remove the skin and the fat that's on top of that muscle, and then bring it and swing it over, preserving this vessel, which supplies this whole area, to then cover it. And this is just a schematic of the skin, the fat, and the muscle, and how we excise the muscle with everything on top of it. Here's an example of someone who's getting their markings of what they're going to be using to reconstruct. And here's a patient, they mark out the muscle and they mark out the area that they plan on using and then dissect it free. And here's the muscle with the skin on top. Same thing here. A little choppy, I'm sorry. But here are some examples of patients that have received it. So here's a patient who has on this side planning to get a procedure done. They mark out the flap here. They dissect it out and swing it over, cover it here, and this is her end result. Here's just another patient, similar thing. She had a defect here. They removed this part of the body. They closed that incision, which you can barely see now, and then swung it over, you can see slight scarring around this, and then she had a nipple reconstructed or tattooed. That's the reason why it looks as it looks. Here's another example. This is for a patient, for instance, that had a vasectomy and wants to get reconstruction done. And for some reason or other, she's not a candidate for some of the other approaches. She ended up getting the psoas dorsi, which is back, brought over and had an expander or implant in place. And then this was used to cover the excess that was no longer there. So they went through this incision here, put the implant expander, and in order to close it, brought this flap across to close that area. And as you can see, she has now volume and also very good comparison here. Yes, it's not natural appearing because there is an incision here all around, but typically that is covered. And from that, when you're using clothes, you can see the superior aspect. It's not noticeable. Satisfaction is about 90% in one study from 170 patients. Complications, seroma. So seromas, our body does not like areas that are empty. It likes to fill it up with fluid. So when we do this dissection of the back and bring it over, that back has a lot of free space. So we typically leave it drained and kind of remove that fluid. If for some reason or other that fluid, when we think the drain, there's an issue with the drain or the fluid is too much, it can cause a fluid collection back there, and that can lead to complications with flap necrosis or just the skin flap itself not having enough blood supply. The muscle itself also functions to kind of use your shoulder, so you can have some debilitating effects from it, such as shoulder movement extension and just bringing your shoulder down. Here are some other complications that typically the highest one is the seroma formation. This is a similar concept, but this is using that one little blood vessel that's coming off the main vessel. So rather than dissecting all the way up here to get to the big vessel and go through the muscle, if there's a perforator, so a very small vessel that goes through the muscle, they can actually use that, dissect it up, and use that skin paddle but leave the muscle intact, not transferring that muscle as you would do with the traditional, which is with dorsi flap. This is what's called the thoracodorsal arterial perforator flap. And here's an example of such. It's a patient who they dissected, they found that little blood vessel. They dissected down, removed this area. They had this little blood vessel here, and he brought it over and covered this area of the breast after the patient had some type of procedure to her breast just to kind of cover that up. Now the abdominal-based reconstructions. I would say these are probably the most common type and the most sought after, just because it's typically a lot of people have access here. Also, it allows people to get kind of a tummy tuck at the same time with their reconstruction, so they kind of get everything. So traditionally, okay. Yeah, no, I think I'm okay. Sorry, I'm just thinking my slide orders. So the traditional one is the tram flap. So this is transverse rectus abdominal myocutaneous flap. Big fancy words. Tram is the shortcut. And what it is that you're removing. There's two blood vessels, one that comes from the chest and one comes from the groin here, that meet up. And what you end up doing is finding that blood vessel, which is kind of marked out here a little bit. You dissect the muscle and the blood vessel together, and then use this as kind of a means of connection, but be able to swing it and leave this defect here, to then bring it up to the breast and then kind of fill in that defect. This was probably one of the very first earlier reconstructions as far as using the abdominal approach for the breast. And this was kind of done in the 1980s. This is very popular, was very highly sought after for patients because it decreases risk if they had they were high risk patients such as smoker, diabetics, and previous chest radiation. This was a great option for them. But there was so as I kind of mentioned, there's one blood vessel here. It goes down and supplies this muscle here, and there's one blood vessel here. It comes up and supplies, and they both connect. This muscle itself is our abs. Its job is to kind of flex and straighten out. And what we do is we remove the skin and the muscle and the fat that's underneath the skin to the muscle, and then bring it up. And it's using the superior artery. So this artery here, this artery ends up getting cut off, but the whole flap is supplied by this artery and it's brought up to the breast itself. Here's a patient who had that type of reconstruction. This is her pre-surgery. This is her post-surgery. She had bilaterals done. and then had our nipples tattooed or reconstructed also. And you can see they're a lot more, they're not as, they're not sagging, they're very full itself. They look very natural. Complications is there's a risk for the fat that's being supplied to be compromised, and this is a high up to 60%. Part of the skin itself, just because we're dissecting things free, there's small vessels that supply the skin. There might be partial loss of the skin, and fascial laxity. So fascia is kind of the strength layer of the abdomen. It's what holds us together, so we don't just have like hernias that pop up left and right. So since we're removing and cutting some of that fascia, it can be hard to approximate that strength layer, and then you can have secondary issues with the fascia not coming together, and this can lead to hernias. And this is also, if you can imagine, you're taking that muscle you use every single day to get out of bed and lay in bed. There's a higher, no longer likelihood for issues with, longer recovery. Now moving to the free flap reconstruction. So this is an example of a free flap. So using the abdomen itself, so taking a piece of tissue with fat and skin, preserving the vessels, but leaving the muscle behind. In this case, the main incision here dissected this blood vessel here from the groin, and then brought it up to reconstruct this breast. And then connected the blood vessel that they removed from the groin up to the chest. And that's what's filling and supplying this area of the breast. And then you're left with one incision here, and then secondary incision, whatever was done on the breast previously before. There's typically two. There's the free tram flap. So rather than just using that whole vessel to swing it up, you just take the muscle underneath the flap itself, then find the vessel and then bring it up, versus leaving the muscle completely behind with just making a small incision on the muscle and dissecting things free to then bring it up to the chest and connect it to these vessels here. So as far as blood supply to these flaps, since we're removing it from the body completely, we have to reconnect it. The two most common ones are the internal mammary, which are the ones that run right here, and then the thoracodorsal, which is the one that runs in the back, where we kind of in the back here. So there's two potential options. And here's an example of such. This is the thoracodorsal, and this is the internal mammary. And these can be used to kind of supply the blood to that skin flap we just removed. Now, this is a very tedious surgery itself. It does require a microscope because it's very, very small blood vessels. And we want to make sure those blood vessels align appropriately so there's no issues with the blood flow going through, causing turbulence and clots, or that the vessel doesn't kink, and then we're seeing issues with the actual wound itself because the blood supply is compromised. So a free tram flap, as I kind of mentioned before, you're moving the muscle. You're removing part of the muscle and dissecting down to those blood vessels, which are right here, which are connected here, and then bringing the muscle and the skin and the fat up to the breast. Smoking is a relative contraindication because of the blood vessels being partially constricted if you're a smoker with the nicotine in your body. So typically you would have to stop smoking before you would talk about doing a free flap for this type of approach. It also leads to the abdominal incision also being compromised because of the different vascular constrictions that nicotine causes in the body. And the actual skin flap itself is the same concepts. Complications, there's a relatively higher risk for wound complications, just because of the tension, partial loss of the graft, and this is increased in patients who are morbidly obese. We'll talk about this one right here shortly. But then there's the deep flap. So the deep flap is very similar, it almost looks exactly the same. The difference is, as you can see here, the muscle is not removed, it's actually incised, and an incision is made on the muscle. The vessels are dissected out all the way to the origin here, and then they're cut there and then brought up to the chest and connected here. The muscle is then reapproximated with sutures. So your muscle in theory is not as weakened as it would be with the tram flap. And this is kind of the blood supply. So if you can see the deep, which is the inferior epigastric artery, the deep inferior epigastric artery, supplies through the muscle and then goes up to the skin and the fat itself. Then you also have the SIE right here, which we'll touch base on that shortly. This is if you can imagine a patient laying down and this is her legs this way and her head this way, with the belly button here, comes from the groin all the way up to the belly button. If you're looking at the patient and they're just laying down with their feet coming through the screen and their head coming through the back part. Oh my gosh. Sorry. The blood vessels go through the muscle this way. So essentially what we do is we mark out the area. We start dissecting from the outside of the body towards the inner part where the muscle is and try to find that perforator or try to find that one big vessel supplying this area. Once we find it, we dissect, we make an incision on the muscle, dissect it all the way down, and then remove it, repair this with sutures, and bring this up to the chest. Here's an example of a patient who had a deep flap. She had bilateral mastectomies. She ended up having excess here that was able to be used. Had an incision here that was used to harvest that excess, and then brought up to her chest and connected. This is her reconstruction. And then this is her reconstruction a couple months down the road with nipple reconstruction, either tattooing or such. So she had a tummy tuck and she had in theory the shape of her breast back. This is a patient I worked on in my training, and I had a very good result. She is a patient that we ended up doing a mastectomy on. So we used an incision here and around the nipple and remove the whole breast that way, lift the skin, as much skin as possible. Had this area here marked out, which we used to harvest and then bring up to this breast. And then this area here we use to harvest and bring up to this breast. And this is her, this is how she looked exactly post-operatively before we took her off the OR table. As you can see, she has volume here. It looks a bit distorted just because it's just fresh and its body's going to fill and scarf things down. And then we have this skin here, which is actually her skin from her belly, which we have a little suture there because we actually monitor the blood supply going to that area with a little machine called a Doppler to make sure that there's still blood supply going to that area. If there's any concern with this patient in recovery, we would have to take her back to reassess what the connections we made. A staggered deep flap. So this is for a patient who's relatively skinny and who was looking for a reconstruction of a breast. Instead of using one side for one side and one side for the other, both are used and they're staggered on top. This is an example, for instance, of that. This is a patient who had a defect here, wanted volume, didn't have a whole lot, but they were still able to harvest both sides and bring it up to reconstruct this area here. And then she had a nipple reconstruction also. So staggered flap is that we have the one area we remove of the body here. We connect it to those internal mammaries, those blood vessels running down our chest. And at the very end of that blood vessel, we connect the other secondary flap. So they're one on top of another to kind of give it extra volume. The SIE flap, this is very similar. I'll show you an example of why I say it's very similar. So this is the SIE. So it's the superficial inferior epigastric artery compared to the deep, which the deep goes through the muscle. The superficial inferior epigastric artery is a little smaller than the deep, but for some patients, this is actually relatively large in size. And as you can tell, the muscle is right here. So we're not even violating the muscle. We're removing the blood vessel at its origin, which is right here in the groin, removing it from its origin, dissecting it off the muscle without making any incision in the muscle. And then if it's appropriate size, we are able to use it to supply the blood area to that flap. And here's kind of a summary of those abdominal approaches. The SIE, which as I mentioned, just those little perforators that are over the muscle that no incisions made. The deep flap, which we dissect all the way down to the origin through the muscle and just suture closed. And the tram flap, which we remove a piece of the muscle and dissect all the way down to the artery and vessel itself. The length of surgery compared to a tram, a pedicle tram, in other words, not a free flap, which taking a piece and rotating over, is very short compared to that of a free flap. And as you can imagine, the more tedious these small vessels are in dissection, the longer time it takes. The length in the hospital is a lot higher though, because we're removing part of that muscle. So you still have to recover. So it may require you in the hospital working with physical therapy on a routine basis to get your strength up so you can be able to go home. And that has decreased over time with these dissections that take longer, but are less debilitating.
I'm gonna pause just 1 second before we go. Okay, so because we're over on time at this point. No, it's great. I mean, I'm in awe, it's amazing. But I just want, because I know we normally do have a stop time around 7:30-ish. I do want you to keep going if you've got the time, and so, yeah, that's perfect. And so, but I just wanna give anybody who might have to go, if you're waiting on a ride, or, you know, just to respect your time. This is being recorded, it will go up on our YouTube channel, and it will get sent out as well. So, please, if you can, and you're, you know, this is relevant and you wanna stay. But I just did wanna take a moment in case anyone was feeling like they need to go, we understand. And again, we're gonna keep going, we'll finish this up, we'll do some Q&A, and then if anyone does wanna stay for a gathering, we'll do it, okay? All right, thank you. Okay,
So as we previously mentioned before, if there's any issues that you're not a candidate for, like a flap from the abdomen or a flap from the back, there's a different areas of our body that we have also have excess tissues, such as the buttocks area, the gluteus area, the love handles, if you want to put it that way. Those can also be used for reconstruction. Here's an example of a patient who had exactly that done. Trying to show you. So this is a patient who had a defect on this side, and I guess potentially looks on this side too. She ended up having this area here, which is supplied by a vessel called the superior gluteal artery, was marked out as far as what tissue, what skin they were planning on removing, and also the vessels where they were located. They can pick up on the machine they use preoperatively. Once they were marked out, she went for reconstruction. This is her final cosmetic result. As you can tell, very well, good volume. You look symmetrical, and this is her donor site. So this is the scar she was left behind with in her gluteal area. Thigh base. So this is kind of using the excess down underneath the belt line and using that for reconstruction. This is not, I haven't seen many patients using this type of reconstruction, but this is very similar to the LD or to the tram flap, where you're taking part of the muscle. So this might cause secondary issues with, you know, rehabilitation afterwards, because you're taking some of that muscle behind. And then taking some of that muscle, you're taking the fat and the skin, and also the two vessels that are coming from the circumflex femoral artery, which is also kind of in that groin area. This is a patient who had exactly that. She had planned, looks like, for a bilateral mastectomy. This is her final cosmetic result. She didn't get any, I'm not sure if this is a bandage or just the skin paddle that they use to assess the blood flow, which she can get tattooed afterwards. But this is her incisions. This is pretty much the incision here. So the muscle is called the gracilis. It's all the way down here. They're taking part of that muscle and then bringing it up, so that that's taking the whole muscle out to then bring it up to the chest. This is a tug flap. This is very similar. It's using actually it's using gracilis, which is the muscle here. Finding the artery that supplies this area, removing that skin and such, and bringing it up to the breast to kind of give some coverage. In this case, in this case, I think it was an implant that was used. You needed excess skin to kind of help the implant stay in place. It's not a lot of volume you can get from this area, but it does give you coverage, kind of cover any area you have a reconstruction. And then the pat flap, which is a profundal artery perforator. So this is another thigh-based one. This is very similar. The difference is that muscle, the gracilis muscle, is in size, and there's a different muscle. They find the perforator. So in other words, the little vessels supplying the skin, they remove those vessels, but leave the muscle behind, and then transfer it to the area. So here's an example of exactly that. Somebody who's planning to get a breast reconstruction, they end up using the skin underneath here, harvest the artery and vein, have it dissected out, bring it up to the chest, connect it to the chest, and these are her incisions underneath. Here's an example of exactly that. Some patient who needed a reconstruction, they end up using this type of approach. She ended up getting an implant in place and using the skin to help cover the necessary area, so to avoid tension. And this is her with a nipple reconstruction done afterwards. And this is her incision. You can barely see it. And that's pretty much it. So surveillance, we do surveillance you afterwards. You should follow up with your oncologist and such. You still can get mastectomies after, even if it's a skin flap into place, just assess for recurrence or even a nevazella. Yeah, that's pretty much it. I know it's a lot. Thank you.
Yeah, we got a question.
Yeah, I just want to say, I had my mastectomies in 79 and 81. And just looking at this and the difference is like, it's fantastic.
Yeah.
And thank you for progressing so much. I mean, it means a lot.
I think the goal is, we wanna, anytime someone goes through surgery, especially when something that you can see, there's an effect, though we're doing a good job of treating the cancer, there's still that psychological, the personal, how you feel.
Mhm.
And we should try to, I think, as far as approaching breast cancer, we have to keep that in mind. We shouldn't just remove things and say, all right, you're cured, you should be happy, you're cured. And then, how can we get you back to your normal being? How can we get you back to feeling like you're still a woman? How can we get you back to still being around your family members without feeling you're the one who just feels different because you look different?
But at that point in time,
It's
that
hard.
wasn't an
Yeah.
issue. They were just looking for a good outcome, not socially, psychologically an outcome, so.
Amazing, and it's amazing how really like with that, how short or how long they've been exploring this whole concept. How short the time frame is with major advances.
Yeah.
I mean, I've even worked on someone with, with like a Halstead,
yeah.
just seeing the difference between that and what I see from, most people who are going through it more recently is incredible. Yeah, and I know there was a lot of information. I am blown now. I mean, I'm so fascinated. So I just want to encourage you, like, if any of this is relevant to you, like if you're making choices, if you're just curious, there was a lot of stuff I saw. I'm like, oh, I'm gonna go back and check that out. So again, you can go back and watch, but are there any questions?
Oh, yeah, I think I got 4.
Okay.
I'll make them short,
Go.
but the reason that it's so important for me is because my reconstructive guy has retired and I'm looking for another reconstructive guy.
Okay.
And so my first question would be is when you have implants in, how long can you keep them in?
In theory, you can keep them in forever.
Forever.
Yeah. Theory, you can
If there's
keep them forever.
no issues, right?
The only thing I would say is like, as time goes on, there's the capsule that's around it can contract a little bit. So, I would say, if you notice anything different, you notice it's getting a little deformed.
Mhm.
Follow up with a plastic surgeon. I know you said your plastic surgeon retired.
Right.
Try to find, I would say probably someone who's recently out of training, just because there's a lot of these nuances we're talking about now that they've been exposed to and they're required to know. So it allows you to get a different set of eyes on you than let's say a traditional. Someone who might just be in their same type of practice, bread and butter every single day. And they can evaluate if there's any need to do a capsulectomy is what it's called. Just to remove that capsule and then exchange the implant out as needed.
What do you mean capsule? What does that
So
mean?
our body normally forms, whenever we have something inside of us, our body forms scar tissue around it. That's what's called a capsule. Now for the breast, this is kind of what we want, because we want a pocket that we can kind of put something in, and then our body forms a capsule around it. A capsulectomy pretty much ends up being when patients have the capsule, it's been there for such a long time, it actually forms calcium. Those calcium deposits kind of constrict the implant. So you notice it's kind of squeezing it, it looks deformed, it doesn't look as it should, feels a little hard.
Does it cause pain too?
Some people can cause pain, yes. Because it's just scarred, it's just getting very a lot of calcium, and that can cause secondary pain too.
Yeah, that's my second question. So I have a lot of pain. Leaking. Because somebody said to me that I should have an MRI done to see if possibly there's leak.
I would say if you notice a deformity, that's definitely looks a little different than the other side, then that's definitely in the differential of what we think about. It just might be a capsule, as I mentioned, just kind of compressing it, or there might be a little leak that's your body formed a secondary capsule around, and that's why it looks deformed, and it can also cause pain. An MRI will help identify that. It can look at things as far as how the implant looks. If it still looks like it's intact, if it looks like it's slightly deformed too because of the capsular contraction and such.
And does it cause, I hear like you to be sick, like different kind of things that happen?
I wouldn't say sick. There's, depending on the implant, for instance, like people who get like silicone injections and stuff that cause an inflammatory response in your body. So it can make you feel groggy and have secondary effects of feeling sick because it's an inflammatory process. So if your body can't get rid of it, it's kind of might be a constant thing. You can always feel constant fatigue and such.
You're answering all my questions.
Good.
I think I just have one more, let's see again. Scar tissue, but keep it in, there you go. Okay, as far as scans go afterwards, after you have all this stuff,
Yeah,
inside
good question.
radiation and all that, and that's all the, whatever. So like, are you done, or do you have to have scans every year?
So, I'll ask you this.
Yes.
Was it both or was it one?
It was both, and it was chemo, and it was radiation, and all the lymph nodes on this side, it was a lot.
So you should still, where I trained before, we used to do yearly MRIs, just to evaluate the implant itself and make sure there's nothing else coming up. So, I would say talk to your breast surgeon, whoever you
Yes.
follow, just to mention that.
Because I made them, I should say made them. I wanted to do a PET scan, and he said, no, you don't have to.
Yeah,
And I said, well, I want to. I said, what test are you giving me to say, hey, has this cancer come back? And he goes, just go home and enjoy your life. And that was my answer. So I'm like, yeah, that's not a good answer.
in your case, an MRI would be the most beneficial, just to kind of evaluate the implants and make sure there's nothing else going in there. Mammograms and it depends how much, I assume you had a full-blown mastectomy, so the likelihood of you getting a mammogram is actually 0 because there's no breast tissue, but
Right.
the MRI helps evaluate the implant. Now, if there's, you notice on the skin, for instance, or where the implants and such, if there's more nodules, like just something that's there that wasn't there before, or a little kind of purpling and such, kind of looks like little blood vessels. That, for me, from an oncology standpoint, raises my suspicion that there might be a recurrence of cancer in that area. And that might require you to get the PET scan that you mentioned and such.
Would an MRI be good?
Not for, so you always want to check elsewhere in your body if there's a recurrence. It's not so much the skin, you also want to check lymph nodes and such. That's where a PET scan can help evaluate that. If an MRI, yes, in theory, can look at the lymph nodes too, but a PET scan will help evaluate if it's metabolically active. In other words, when you get a PET scan, they give you an isotope. In other words, an abnormal form of glucose that is picked up on the scanner. So when your body uses that glucose, it gets accumulated in certain areas. When things are hypermetabolic, in other words, using a lot of sugar, because it needs sugar to survive, they light up. And that's when those areas that light up that are abnormal, that shouldn't be things that light up, or what we get concerned about, that they're metabolically active. And they require them further workup with biopsies and such.
Okay, only one more, I promise, real short. Okay, if you have an implant on the side where you had the radiation, and as you said, usually they take all that out before they radiate. Well, they didn't. They kept it all in, implant and all that, and then they radiated for 37 days.
Okay.
Okay, and so my question would be is, because I asked her, but I just want to take it out, because the other side I had 4 infections in 3 months, so I had that one out. So I said, I'm deformed anyway, so just take the other one out. And he said, no, you can't. And I said, why not? He said, because it was radiated then.
I don't think that's a contraindication to get it removed. That's my personal opinion. I guess it depends who you talk to. I would say the risk of you having capsular contracture in that area is probably a lot higher, especially if the implant is in place.
He said it would be hard to heal because it's radiated on.
It might, it's unfortunately,
I know.
who you talk to,
I
I
know.
can't 100% say.
Well, it gives me an idea of, where I want to go with this, because he was very surprised because the side that was radiated on, I had no issues, no infections. Skin looks like baby, like a 2-year-old baby. But on the right side where there was nothing, 3 infections. So it doesn't always hold true if it was radiated on. So
Yeah.
that does answer all of them for me. Thank you. I don't want to take over time.
No, that's great.
Thank you.
It's helpful for all of us.
Thank you.
Anybody else have any?
I've got 2 for the,
Oh, perfect.
for,
For the Zoom?
yeah, for Zoom.
Awesome.
Let's see. The first one is with some of the procedures, don't you move the tissue under the skin to the new location?
Yes, so the tram flap is typically what we do. We tunnel it through the abdominal, not the abdominal wall, but the tissue underneath the breast and bring it up. And the latissimus dorsi, back flap, you can also do the same thing. So those are what we call local rotational flaps. So it's local area close by, and we rotate it to kind of cover the area that we need. when it comes to the breast, we of course don't try to make another incision, pass it through, we just use the same incision that we're planning reconstructing the breast with. And then make a tunnel underneath the skin so you don't see it. So it's the incision where your breast mastectomy was, or the flap is, and we just tunnel underneath the skin, then close both incisions. So that's with the tram flap and the incisional dorsi flap.
Perfect. And then Linda wants to know, what is the chance of getting lymphedema with these surgeries?
Good question. So, for lymphedema, I would say there is an increased risk when you're using a thigh-based approach. Just because you're removing the lymphatics that's draining from the legs up to the rest of the body. So there's a higher risk of lymphedema. I don't know the exact percentages off the top of my head, but that one definitely there's a higher associated with lymphedema. From the back flap, not so much. In the abdominal one, there's a small likelihood, but not a whole lot, because you have deeper lymphatics in your abdomen that are not being touched, and their lymphatics are going from your groin down into your abdomen and then going to the rest of your body. But it's usually the ones that are superficial on like one leg specifically, since you're kind of going around, partially around that area, there's an increased risk for lymphedema.
Thank you. And that's it for these questions.
Good questions. All right, anybody else? All right, well, I think that was amazing. I know personally, having had, I mean, I bet a bunch of us in here are kind of seeing ourselves, or at least have more information. And so thank you so much for all of that. I know I'll go back and watch it. And if anyone does have questions, this is a great jumping off point, right? To take to your doctor. Obviously, if you ever need, if you're looking for new doctors, like we've got a lot of people who are now especially, connected in different practices, different health systems. So we can always help you reach out to someone. And just thank you for your time and for all of the effort that you put into this. So thank you so much.
Yeah. You guys do what you guys. This is all.
Well, thank you. Thank you so
I'll
much.
tell you that once. And it's
All right, so otherwise, I think, is anyone interested in staying for a little bit?